with the Shelbourne Knee Center podcast. Welcome to episode 11. Tonight we're going to talk about the management of patellar tendon ruptures, and Scott Bauman is here. My co-host is here tonight as well to give us a rehabilitation perspective as well as participate in this discussion about how to take care of this problem. It's one that can definitely be difficult, but we have a specific way we like to manage these we wanted to share with you all tonight. If you want to contact us or follow us, find us on Facebook at the Shelbourne Knee Center podcast Facebook page, or on Twitter and Instagram at the SKC podcast, or feel free to email us at the SKC podcast@gmail.com.
We're going to kick off this discussion really where everything starts. Can you walk us through the mechanism of injury for patellar tendon rupture?
Yeah, it's a pretty specific mechanism of injury. It's usually during an explosive type athletic event when it happens to athletes. So we see this in basketball players, sometimes volleyball players, people like that are doing explosive jumping, and it usually is a rapid eccentric load. Somebody that's going up for a dunk or landing from a jump from a height, things like that, and that rapid eccentric load just generates a tremendous amount of force at tendon attachments to bone, and specifically around the patella tendon at the proximal attachment to the patella can tear in that area. So that's usually the mechanism.
Now, once the patient tears their patellar tendon, they come into your office. What's the typical presentation of somebody that does this?
It's a big deal injury. From the very beginning, the patient knows that something is very wrong with their knee. They usually feel a big pop or a tear across the front of the knee. They're often kind of horrified when they look down at their knee and they can see that their kneecap has traveled up their thigh higher than it should be, and that there's often a pretty visible defect below it, especially before it starts to fill with blood and swelling from the injury itself. So usually a big deal injury. The patient often will be taken to an emergency department where they'll see somebody at the beginning to make sure they haven't broken anything, or kind of do the emergent evaluation. So a lot of times these patients come into clinic after they've already been seen. They're in a knee immobilizer, on crutches, or in a wheelchair, and these people can look pretty bad when they come in, as opposed to the majority of our patients that walk in the door. From a subjective standpoint, the patients usually describe, as I talked about before, a popping or a tearing sensation when they were landing for a jump or doing something explosive. And in older folks, I guess, in people who are older that aren't necessarily doing this with athletic participation, we see a lot of these from slipping on the ice, that people go out to shovel off their driveway or to go out to get the mail or to take the trash out, something like that, and they slip on the ice with one side and they try to catch themselves, and that gives them that rapid eccentric load. So sometimes it can be a simple fall or a slip and try to catch themselves that generates that force from a rapid eccentric load.
So once you get this patient in your office and you recognize it's a patellar tendon rupture, you're working on the acute management of keeping swelling down and whatnot. Obviously, this will go to a surgery case. Is that something where you're rushing right into a surgery, where you're doing it that night, the next morning, or is that something you feel like you can push off for a few days?
Well, luckily, from a diagnosis perspective, it's pretty easy to make the diagnosis. Patients come in and describe that to us, and then when you look at them on physical exam, they have a lot of swelling around the patella tendon area. They say, I tried to get up, but as soon as I tried to get up, I fell back down again because I couldn't straighten my leg out. And then eventually, I kind of figured out that I couldn't keep my leg straight, couldn't lift up my leg, and that loss of active extension is what can make the diagnosis. There's also usually a palpable defect at the inferior pole of the patella, or sometimes a little bit further down if it's a mid-substance or distal rupture. But usually this is a pretty easy diagnosis to make, that the patient can't actively extend the knee and that there's a palpable defect. In the early time period, when I was going through training, I was always taught that this is an urgency but not an emergency, that it probably needed to have the patient admitted to the hospital or done within the next day or two to try to get this done as quickly as possible. And the reason is because the quad muscle wants to pull that patella more proximally, and there's always worry about if the patella comes up proximally and starts to scar in that area, that the patient's going to lose motion or have a patella alta that would be more permanent. However, when I got to Shelbourne Knee Center, started working with Dr. Shelbourne, we started to handle these in a little bit different manner, in more of a subacute manner. So we like to get to these not necessarily urgently. In fact, the opposite. We like to give these people a little bit of time to get the swelling down, to even start to move the knee somewhat into some range of motion, to let the soft tissues around the knee calm down. And we feel like that it's an easier surgery surgery, and that the soft tissue is kind of congealed in that area. Those ends of the tendon are a little bit more robust and easier to suture, and that also the patients are in less pain, have less swelling, have less soft tissue edema. We're making our incision, which we think may help with prevention of infection risk. A lot of people will tell you that you have to handle these right away. We look at it a little bit different, usually trying to get these on the schedule within about 7 to 10 days.
Yeah, that was my next question is if you can delay this a little bit, is that 10-day really the cutoff? Or is there any time where you'd say, yeah, that's a little bit too late? You know, if somebody's on vacation or whatnot, they have a reason why they don't want to do the surgery right away. Would you really push that at some point?
We've definitely had people that have come in later than that. Dr. Shelbourne likes to tell a specific story about a guy that he knew that had injured himself when he was in Florida. You know, we're in Indianapolis. Some of our patients are in Florida for the winter, and he came back like 6 or 8 weeks after his initial injury and said, I knew that I needed to have surgery, but I didn't really want to have it when I was in Florida, even though they told me I probably should. I figured you could just fix it when we get back to town. And it was 2 months later when he got this fixed. And luckily that patient went on to do more. It's definitely a different animal if it develops into more of a chronic rupture. I've had probably 4 or 5 cases in the last few years where patients have come in with missed ruptures where they didn't know that they had a patellar tendon rupture, didn't go and see anybody, and it's developed into more of a chronic tendon rupture situation. That's a totally different animal. But if we're getting to these relatively acute, there's not really a maximum time, but for us, the golden time is kind of in that 7 to 10 day area. I think anything more than about 2 or 3 weeks, you better be getting this done as soon as possible.
So let's talk about the typical patient, and you're seeing them 7 to 10 days after injury. Can you walk us through and tell us a little bit about what the surgical technique looks like in this patient population?
Just a quick note, we'd like to see them a little bit earlier than that. We like to get these patients into the office as quickly as we possibly can, even though we're not going to do the surgery right away. But for initial management, we put patients in a thigh-high TED stocking to give them some compression. We put them in a cryo cuff to try to decrease the knee effusion. And we actually preoperatively will put these patients in a CPM machine. And I know some people are probably going to think that's a little bit nuts, but I've seen some real improvements clinically in these patients over that 7 to 10 day period where that consistent elevation and that little bit of gentle motion helps to get the swelling down and helps to make them actually more comfortable. It seems counterintuitive that if you bend the knee that you're going to be pulling the tendon rupture apart further and that it's going to be very painful. And we find quite the opposite. The patients come in and can barely move their knee and they're in a lot of pain. You put them in the CPM machine, bend their knee just from 0 to 30, just a little bit of gentle range of motion. And then as the swelling goes down and the knee gets more comfortable moving, the patient's in less pain. And I think that helps with the pre-surgical preparation and with the post-operative recovery, helps them keep them in a little bit less pain. From a surgical technique perspective, this is 100% of the time a surgical problem. There's a lot of things that we do that are difficult discussions with patients to try to figure out who's a good candidate, who's a bad candidate. Will patients get better non-surgically? Will they not? In this particular problem, the discussion is much more straightforward. Unfortunately, there really isn't a good way to manage this non-surgically, and this is pretty much a surgical discussion 100% of the time. There's really 2 main ways to go about fixation of a patellar tendon rupture. When I was a resident, I learned the technique that I don't necessarily use anymore, which is to use a beef pin that we use for ACL surgery with an eyelet at the end of it to drill holes in the patella. So you one up the middle of the patella, and then one on either side. So you have a medial hole, a lateral hole, and a central hole. And then when you use your suture technique up and down the patella to grasp the patella and then pull it back, then you run those sutures up through those bone tunnels and tie it over the top of the patella, which kind of pulls that back to the inferior pole of the patella. We usually use suture anchors for this instead of doing that technique. I think that first one, tying it through bone tunnels over the top of the patella, is probably biomechanically even a little bit superior, but it's definitely a lot easier to use suture anchors. So we like to put suture anchors in the inferior pole of the patella or wherever the rupture is, and then use those sutures that come out from the anchor to go up and down the patella with a grasping type stitch, a Krakow stitch, which is a grasping, running, locking suture that really grasps the tissue well, and then use that to tie it back down to the patella.
So when talking about the surgery, I know there's different ways that surgeons can augment that repair. Is there any type of augmentation that you use with this patient population?
Yeah, there is, and I think that's a really important part of what we do differently. That we use a braided metal cable to try to augment the repair, and that really provides a couple specific advantages. When I was learning how to do patella tendon rupture repairs, I was always told to extend the knee and get the tendon back up to the patella, and we kind of do it a little bit differently in that we use that cable to pull the patella down to the ruptured tendon. So we make sure that we don't fix the tendon in too proximal a position. So when we do this, we'll put the suture anchors in, we'll run the sutures down and up the patella in a running interlocking fashion. So we have that good tendon interlocking suture that's going to pull it back up to the patella. And then we'll drill a hole across the patella at about a third of the way down from the proximal end of the patella, and then run a 2 millimeter or 1/6 millimeter braided cable through the patella, and then we'll also go down distally, just distal to the tibial tubercle insertion, and drill a drill hole through the tibial tubercle as well, and put the cable through that. And we then will measure the lateral view of the opposite knee, the uninjured knee, and figure out what the patella tendon length is on the normal side. Once we have that, then we'll pull the patella down with the cable in order to get it to the same length as the other side. And then once we've set it at that length, then we'll crimp the cable before we even suture the tendon back together. That holds the tendon at a fixed length, and we do that at about 60 degrees of flexion. So we'll put a bump underneath the leg, let the knee come down into some flexion after we have the cable in place, and then we'll actually tighten the cable to pull the patella distally down to the tendon rupture, and then crimp it at that specific length. Once we have the tendon at the right length, then we go ahead and tie the sutures, which actually does the job of, specifically pulling it down to the patella tendon insertion. And it's a technique that I learned from Dr. Shelbourne that I think is an excellent one, because it allows us to hold the patella through a fixed length and be more aggressive from a physical therapy standpoint postoperatively, which we'll talk about a little bit later. There are other methods of tendon augmentation. Some people like to use allograft or even sometimes autograft hamstring tendons. That's more in the chronic state, but sometimes even in the injured state, if they don't feel like the tendon's of good quality. There are different kinds of biologics that could potentially augment the patella tendon repair. There's other kinds of like fiber tape and other kinds of suture devices to try to augment the patella tendon repair in some way. However, we like the cable because of how rigid it is, that it can hold the tendon at a fixed length and can allow us to be a lot more aggressive from a therapy perspective.
Sounds like there's a lot of benefits with the braided cable. Are there any downsides to this versus other augmentation methods?
No doubt there is. There's the extra operation to take it out. The cable, while it does a good job of protecting the repair throughout range of motion early on after surgery, allows us to be more aggressive and not lock the patient up quite so much from a function standpoint. There is another operation that needs to be done later to take it out. As we talk more about the rehabilitation goals that we have early on, or the rehabilitation progress that we have early on, we believe that really sets it apart and makes it more than worth it for the second surgery. The second surgery for the cable removal is a pretty simple one. We make just a portion of the incision, probably a 1 or 2 inch portion of the incision, dissect over to the cable where the clasp is, cut it, and then pull it out. The tourniquet time on that surgery is literally less than 5 minutes most of the time. And then we close the incision back up, and the incision closure takes about as long as it does to remove the cable. So it's still surgery. The patient's still going to sleep for an operation. There's still a risk of infection and things like that. However, knock on wood, we have not had trouble with cable removal surgeries leading to complications after that. And it's a pretty low risk operation that we believe is more than worth it for the benefits that we get from it.
Now, is there an average time from patellar tendon repair to the cable removal?
It's not necessarily a specific amount of time. It's much more about their range of motion progression. So we actually let these patients flex their knee early on after surgery to pretty much whatever they can tolerate. We do assess that during surgery, how quickly there becomes a lot of tension on the repair, but more so in quad tendons than patella tendons. In quad tendons, we don't have the ability to augment it in the same way because we don't have any bony attachment proximal to the quadriceps tendon to make kind of a box around the repair. On the patella tendon side, we do, so we can get pretty aggressive with range of motion, even right after surgery, even the day after surgery, to try to maintain function as best we can. Eventually, though, the cable becomes limiting to flexion. That's usually when the knee gets to about 110 to 115 degrees of flexion, and it's usually around the 6 or 8 week time point that starts to restrict their range of motion. 6 weeks is kind of a minimum because we think that does take at least that much time to be able to get the tendon to heal, but it's really determined by when it becomes limiting to range of motion. And that kind of transitions naturally, Scott, into you talking a little bit more about how we rehabilitate these patients. So as we talked about, I do the repair, I assess in surgery how aggressively I think we can move things, and then I turn this over to our physical therapy staff. So early on, talk about what the early rehabilitation after a patellar tendon rupture with cable augmentation and what that looks like.
Well, to start this conversation, I will say that treating a patient after a patellar tendon repair using a cable like this is really a physical therapist's dream, because there's really not anything that we're going to do that's necessarily going to hurt the repair. When you're seeing these patients in a setting that's outside of our office where they're either using soft tissue augmentation or no augmentation at all, you really do have to limit how much flexion, especially, that you give the patient or allow them to go to, because they are going to pull on that repair with every increasing degree of flexion that they can get to, and you have to limit that usually per the surgeon's protocol and what they feel like they can let you do post-operatively. So outside of this setting, it's a really close relationship with that surgeon to get a sense of how far to go and how much more you can take them each and every increasing week. However, with the way that we manage these from a rehabilitation standpoint, it really is pretty easy. We really focus on swelling management and range of motion to start. So you mentioned the CPM preoperatively. We do have these patients in a postoperative CPM as well. Same thing as preoperative, though. They're moving from 0 degrees to 30 degrees, just having some gentle motion, mainly to keep that knee elevated, to keep the swelling to an absolute minimum, and using a cryo cuff to prevent more of a hemarthrosis. So that's the really acute period of the first week or so. We do give them some motion exercise to work on, your typical extension exercises like towel stretches and heel props and things like that. But typically in this patient population, extension is not something that's really difficult to get back. It's really about how much you can and how fast you can get their flexion back, which again, after about 6 or 8 weeks, you start being limited with deflection based on the cable. But that's in my opinion, it's a good problem to have, because you really are pushing things. And if the cable is limiting them, then you take the cable out. I always tell patients it's really more of a speed bump of recovery versus, altering the path of rehabilitation. So the big focus in those first 6 or 8 weeks is going to be flexion progression. And like you said, we typically see it max out over the course of the first 6 to 8 weeks at about 115, 120 degrees even. And then you will feel a hard stop. It's not one of those where you're questioning whether or not it's the cable that's stopping the knee or not. You'll feel that cable tension, and the patients will just tell you, yeah, I just can't go any further because it feels like something's stopping me, and something is stopping them. It's the cable. So that's when we get in touch with the surgeons again, and we schedule the surgery for the cable removal. Now, the other thing that's nice about the cable is once we get to that 6 or 8 week time point, because we have the reassurance that the repair is going to be protected by the cable, we can move into some light strengthening exercises, even low impact conditioning. You only need about 105, 110 degrees to get around on a bike. And we definitely get patients that still have the cable in up on a bike. And if they have 120 degrees of flexion, they're doing some light strengthening and some light biking to help condition that knee until they get that cable out. One thing I didn't mention earlier is the leg control aspect of things. So we mentioned the focus is keeping swelling to a minimum and keeping range of motion progressing forward. We do want to make sure that leg control is normal. We have these patients in a knee immobilizer for generally about 2 or 3 weeks, and there's really no time stipulation to that. It's basically whenever the patient has full leg control, and that's typically seen after a couple, maybe 3 weeks for patients that are a little bit on the slower end. But once they have that normal leg control and they can do a straight leg raise on the table, they can do a knee extension off the side of the table, we feel pretty confident that they can walk without the immobilizer. And like I said, that's usually about that 3 week time point. And then again, it's flexion progression, get them on the low impact conditioning like a bike, and then start some light strengthening until that cable comes out.
That's a lot different than what I saw in training. And I was really surprised when I got back to Shelbourne Knee Center, started seeing some of these patients, how much more quickly they were progressing than what I had seen in training. A lot of times these patients were in a cast or in a knee immobilizer brace that was not being removed at all for the first 6 weeks. By the time they got to the 6 week mark, that quad had really kind of shriveled up. The knee was very stiff. The patient hadn't had much ability to get around and do much from an exercise perspective. And it was a long way to go from the time you got past that six week time point, started moving the knee for them to really return to function. However, our patients are able to start bending the knee right away. A lot of these people come back even at the 2-week mark and have 90 degrees of flexion already. And once that, you mentioned the bracing is only a temporary measure, only when they're up. We let them weight bear to tolerance from the very beginning. And we also let them out of the brace whenever they're not up and weight bearing. And, we've seen a couple of these patients that have come from elsewhere that have had complications on down the road. Or if I think back to when I was in training, when I would see these patients at that 6-8 week mark after they'd been in an immobilizer and what the leg looked like versus our patients that at 6 or 8 week time point, what they look like. These patients in our hands at the 8-week mark have full extension. They have flexion a lot of times of about 110, 115 degrees. They have good leg control. They are walking without an immobilizer. They can easily lift their leg. Some of them can tolerate some biking and some light knee extensions with a weight over the end of the bed. So a markedly different thing. And talk a little bit about that, Scott. Did you see any of these patients before you worked at Shelbourne Knee Center, and how did those compare?
Yeah, I absolutely did see these before I got to the Shelbourne Knee Center. And to be honest with you, they were very tough to treat. And a lot of the reasons was because of what you were saying. You had to be very slow with the rehab because it was a delicate repair. And the last thing you want to do as a physical therapist is upset the surgeon. And if you're having a patient that had a patellar tendon repair come back at an 8-week visit and they have 150 degrees of flexion, that's usually not a good thing because you probably let them go too fast or they didn't listen to you or whatnot. So it's mentally tough. It's physically tough for the patient to limit them because they usually feel like they can go further. And I'm talking again before I got here when they don't have any type of augmentation. So from a physical therapy standpoint, it was honestly just very difficult, and the patients were hard to manage, and the long-term outcomes were challenging because if you limit them so early, so much in the early time point after surgery, the ability to get, let's say 150 degrees of flexion is normal to their other side. If you're limiting them to 60 and 70 and 80 and you're increasing 5 or 10 degrees per week for the first couple months, they're still only at, maybe 90 degrees at that point, if that. So, like you said, a lot of other protocols will just have rigid bracing or something for a period of time. And that makes the patient pretty stiff to the point where they may never get back to full flexion in a scenario where they're not having it augmented like we do here.
That's something I had to change the paradigm around how I thought about these as well with this method, is that I think a lot of those patients are told, especially older patients that may not be that athletic, that may have torn their patella tendon, slipping and falling when they were mowing the grass or shoveling snow like we talked about before. I think a lot of those people are just told, unfortunately, you're going to lose some bending, your knee's going to be weak, and that's just part of recovering from a patella tendon rupture. And I think, unfortunately, that does sell some of these patients short, that, that this is kind of sold to patients as this is something that is going to lead to you having less than normal knee for the foreseeable future. And we really like to use the cable, even though it does require another operation, to be able to say, we're not going to accept anything less than what's the best we can get for our patients, and and utilize all the advantages that we can. Scott, talk a little bit about what the patient's progression is like after we take that cable out. How do you handle the post-surgical rehabilitation, and how do those patients progress?
Sure. And like I said, when I talk to these patients that are getting ready to have the cable removed, I tell them it's really just a speed bump in the recovery. We don't have them typically have the CPM anymore. It's usually only a 3-day relative bed rest period compared to the 1 week like we had with the repair. They go into surgery with full extension, really minimal swelling. Again, they've been working on the biking. They've been working on light strengthening. They were maximized on their flexion before the cable removal surgery because the cable was limiting them. And usually that's around 120 degrees. And they come out of surgery and they can usually get 125, 130 degrees, so about 5 to 10 degrees more at that first visit, which is 3 days post-op after the cable removal surgery. And because we still have minimal swelling after that, they get their motion back pretty quick. Typically around 4 weeks after cable removal, they're going to be equal to the other side from a knee extension and flexion standpoint. And then swelling, again, is so minimal after this cable removal surgery that they really have minimal to no swelling a month after the cable removal. So now we're talking from the primary surgery where they had the tendon repaired. is usually about 3 months, because you're about 2 or 3 months after until you get the cable remover out. So from the initial surgery, they're now 3 months out and they have full motion, minimal swelling, and they've been working on strengthening. And we even strength test these patients usually about 4 months out from the original repair, so maybe 2 months outside of the cable removal surgery. And they're usually about 75% or so compared to the other side. And because we really hit the motion goal so quickly after the cable removal, we can really work into the strengthening. The benefit of the cable is they've been utilizing strengthening exercises to gain strength before the cable was taken out. So they just really hit the ground running after surgery. And it's really a continuation of the rehab that they were going through with the cable when the cable was removed. And then again, we continue to strength train and strength test these patients, and we typically see what we would call symmetric strength, 90% or more from an LSI standpoint compared to the other side, usually after about 3 months after the cable removal, which puts them about 5 or 6 months post-op from the initial surgery.
I'm always surprised at how quickly these patients do progress once they get the cable out. They get up to the point where they're 90 degrees, they're 100 degrees, they're 110, then about 115, then they kind of stop. And you wonder, if I take this cable out and they push it really aggressively, how quickly is that going to progress? And is this going to put my repair at risk? And I'm always shocked that when, people, when I see these patients 2 weeks out, 4 weeks out, something like that, how quickly they're able to get the rest of their flexion back once the cable's out, and that the x-rays don't show that there's been any proximal translation of the patella. We've had enough time where the tendon has reliably healed. So, I think just in closing up with this group of patients, just not selling these patients short, that even though it is another operation to augment with the cable, I think the benefits definitely outweigh the potential risks.
Well, and to touch on something that is related to that point there, I think the mental aspect of rehab is so much easier when the patients are augmented with a rigid fixation like the cable. And that's before the cable is removed as well as after. When it's in, they have all the confidence in the world because they know that there's something rigid. It's a steel cable basically that's not allowing them to hurt the repair. There's constant affirmation to the patient telling them, you can push this to the point where the cable is going to stop you. And they always question you. There's just no way. I feel like I'm going to rip my repair. You're not going to rip the repair. You're going to hit the cable. That's the whole point of what the cable is doing. So they gain confidence not only in you, but they gain confidence in their own knee going through the rehab with flexion. And then after the cable's removed, you mentioned that they come back pretty quickly with the rest of the flexion as well as the strength. And I attribute that a lot to the confidence mentally that they gained before surgery or before the cable removal surgery. They were trusting their leg. They were putting weight on it. They were out of the immobilizer after 2 weeks. They were starting strengthening exercises as early as 4 to 6 weeks after the primary repair, to the point where the cable removal takes place. They really do hit the ground running. And they have so much confidence, and I do attribute that a lot to the fact that they had the cable in there that gave them that confidence to progress so quickly.
If you'd like to learn a little bit more about some data that we've had from a previous study on this, my partner, Dr. Shelbourne, and one of his former fellows did a study on this. It was in the American Journal of Knee Surgery. It's referenced on PubMed in winter of 2001, entitled Patellar Tendon Rupture Repair Using Dahl-Miles Cable by Shelbourne and others. And in that study, they looked at 10 patients who underwent patellar tendon repair with the cable augmentation as well, that went through this early rehabilitation that we're talking about. The cable was removed around that 6 or 8 week time point. And if we look at flexion in these patients, their average flexion at 2 weeks was 88 degrees. By a month, it had improved to 112 degrees. Around the 2 month time, they took the cable out. By the 3 month mark, they were at 133 degrees and 136 degrees at 6 months, compared to 141 on the non-involved knee. So you see the patients did progress as quickly as we're talking about. Mean quadriceps strength was still down in that group at 72%, but I think this is a 20-some-year-old study. I do think we've gotten progressively better over time. Probably something we need to revisit and republish again to show what important improvements the patients have been able to make over time. The interesting thing in talking to Dr. Shelbourne about this population is how much of this stuff he was able to learn about this population specifically by just observing patients, which has always been a way that he's learned a lot of things, but specifically as it related to things like active knee extension early on after surgery. Also, as far as like how far to let these patients go with flexion, He tells stories specifically about going in to see patients afterwards that have their leg in the CPM machine, and he went in, so how's the knee feeling? And they said, yeah, my knee's feeling better. Look, and they lift their leg up the day of surgery when he had told them, oh my gosh, don't do that. They'd done it anyway, and it scared the crap out of him, he said, and he couldn't believe that, went to examine the patient, make sure they didn't tear anything up, but then started to think after seeing that a few times, you know what? Why should I stop them? The cable's in there. It's protecting the repair. And now I ask the patients to do that after I fix the patellar tendon rupture. Can you lift your leg up? And if they can do it under their own power, I allow them to, because the cable has them protected. I would bet that if we looked at our research database for these patients, that we would see as good or maybe even a little bit better progression of the flexion nowadays compared to when we used to do them. But that's something we definitely need to continue to keep looking at.
So that about wraps up the episode on management of patellar tendon ruptures. And just to summarize it, especially from a physical therapy perspective, it's really an easier way to treat this patient population. When you augment it with a rigid fixation like the cable, you can be pretty aggressive early on with the flexion, because, again, you're protecting that repair with the cable. And like Dr. Benner had mentioned, the downside of this method is the fact that you have to have another surgery to take the cable out. But it's a pretty quick surgery, pretty benign surgery. It's a very easy surgery to recover from, and really just hit the ground running from a rehab standpoint and progress on with finishing off the range of motion and then starting to work on strengthening until that's really equal to the other side, which, again, is much different than utilizing other methods that is not augmented or augmented with some type of soft tissue augmentation. If you have any questions on today's episode, or really anything that you want to have answered from previous episodes, you can visit us on Twitter and Instagram at the SKC Podcast. You can visit us on our SKC Facebook page, or email us at the skcpodcast@gmail.com. And we'll talk to you guys next week.